Hi, this is an evidence-based practice review presentation by Tierney and Agnes. Agnes and myself reviewed a selected body of literature to assess the impact of low socioeconomical status in development of type 2 diabetes in African Americans. Our PICO question is as follows. Are African Americans of low socioeconomical status at a higher risk for developing type 2 diabetes, and what interventions can be implemented to provide better glucose control for African Americans who have type 2 diabetes? Over the years, research has shown that social economical status impacts many aspects of a person's life. Social economical status can influence a person's diet, physical activity, educational resources, and recreational facilities. People living in low-income environments, specifically African Americans, have an increased rate of diabetes and other chronic diseases compared to people living in better socioeconomical areas. Evidence shows that individuals with low socioeconomical status are more vulnerable to diseases and have poorer health outcomes. Exploitation of these risk factors and lifestyle modifications may effectively reduce the prevalence and or improve health outcomes for African Americans with type 2 diabetes. A total of 5 databases were used to obtain 5 articles selected for review. Keywords and phrases used to locate the material were social economical status, type 2 diabetes mellitus, African Americans, interventions to improve glycemic control, effects of low socioeconomical status and diabetes, and African Americans of low socioeconomical status with diabetes. The chart shown contains the type of evidence, the authors, and information regarding the sample and settings used in the article selected.
In this results section, there were 5 research articles that were used, and those same articles were used in the evidence table. All those articles, out of them, there are 4 randomized control and 1 descriptive. The first article, Robin et al., examined the relationship associated with poverty income ratio, education, occupation status associated with type 2 diabetic among African American and non Hispanic whites, through unhealthy behaviors, inadequate access to healthcare, nutrition inadequacy, and other circumstances such as psychological stress. However, once modifier risk factors were adjusted, a strong association between PIR and type 2 diabetic remains significant after other risk factors were adjusted. Poverty income ratio was strongly associated with diabetic prevalence among African American. A randomized control study by Meyer et al. Also examined the impact of 8 peer-led diabetic prevention workshop on weight and diabetic risk among low-income, largely Blacks and Latino populations. In this study, the intervention group took part in 8 90-minute peer-led workshops that focused on portion control, sample labeling, managing monthly food budget, learning to cook healthy food with limited resources. The results indicated that cutting down the intake of unhealthy foods and drinks, reducing sedentary lifestyle, environmental factors that promote unhealthy habits, and strategies to deal with stress and emotions negatively impact health. Therefore, all this led to the significant decrease in weight compared to the control group and a decrease in the probability of developing type 2 diabetic. Another researcher, Crowley et al., conducted a randomized control trial which evaluated the effect of cardiovascular disease risk reduction intervention in African American women with diabetic. Their intervention group took part in self-management, education, and medication management. The findings indicate that intervention group patients were significantly more likely than the usual group to report improved medication adherence from enrollment to the end of the study. This shows that self-management support and quarterly medication management facilitation led to improvement in medication adherence. In Cummins et al., their findings illustrate the unique disease management challenges faced by African American women from impoverished rural communities who have limited education, low income, and rely on food assistance programs in contrast to those of participants in typical diabetic and weight management programs. Their findings also indicate that African American women or African American in general from impoverished rural communities exhibited significantly uncontrolled type 2 diabetic of long duration with associated obesity and poor lifestyle behaviors. In this last article, Lynch et al. Conducted a diabetic self-management education session, which consisted of a short physical activity, healthy snack, nutrition education, group discussion of goals, progress and barriers faced for behavior changes. After the program, they realized that there can be lifestyle improvement through dietary changes and exercises which can decrease A1C levels after either 6, 12, and 18 months of treatment. Nutrition knowledge also improved quite a bit, with probability of 0.02 and an improvement in quality of diet of about 0.018. After examining all these articles, our overall conclusion is that socioeconomic inequalities are associated with inadequate access to health care, unhealthy behavior, psychological stress, inequalities in access to materials, and inadequacy in nutrition are all risk factors for type 2 diabetic in African American. And those that are of low socioeconomic status are exposed to such risk factors that predispose them to type 2 diabetic. However, with that being said, education regarding diabetic mellitus, physical activity, healthy diet, and adherence to medication can greatly reduce the prevalence and or could provide better management of type 2 diabetic. These are the list of references used throughout the research. Thank you.